having diabetes increase the risk of cataracts by 2 to 5 times.
Cataract.
Diabetes, cataracts,
Cataract.
diabetes patients.
When there is a disturbance in the metabolism, the nutrition of the whole body is suffering. And cataract also depends on the nutrition of the person.
Reducing alcohol consumption slows the cataract progression. Is it true?
Very sure that is true. Alcohol is a zero nutrition calorie.
That toric lenses rotate. Sir, how do you manage this challenge and ensure successful outcomes?
Toric lenses have a cylindrical power and they have to be fixed at a particular angle. So you have to take the cataract out and put a lens in and rotate it to a position where it connects the astigmatism completely and fully.
Sir, why there are halos and glares on the trifocal IOLs?
The trifocal lenses have multiple rings. If you see in the dark towards the light, you will see that there are rings happening all around that light, which could be very large and can be incapacitating if you are driving.
Welcome to DocPod. Here we will have discussions on research and latest advancement in medicine and science. At DocPod, we aim to advance ophthalmic education in our country to encourage research and innovation. In today's episode of DocPod, we have invited Dr. Sudhank Bharti, who is one of the pioneers in cataract and refractive surgery in India. He did his study from England in 1984, and in 85 he came back to India and started his own practice from a basement clinic. Now he is running 5 hospital chains in Delhi by the name of Bharti Eye Hospital. By nature, he is also an philanthropist and runs a Bharti Eye Care Charitable Trust, which does 2000 cataract surgeries in a year for free for the poor and rural societies of India. In today's episode of DocPod, our episode is divided into 3 sections. The first is the life journey of Dr. Sudhank Bharti. The second one is related to patients and the problems related to cataracts and how they can solve it. And the third section is related to the peer-reviewed papers of Dr. Sudhank Bharti. The first paper is a comparative study between EDOF and trifocal IOLs, and the second paper is a case report of bilateral toric phakic intraocular lens implanted in a patient having a Marfan syndrome. So let's welcome him. Hello, thank you so much, Dr. Sudhank Bharti, for accepting my invitation to be on this podcast. It is my honor that I am sharing a seat with you. Thank you so much, sir.
Thank you. Thank you very much for inviting me. Thank you.
Sir, today we are going to talk about the complications of alcohol with the cataracts, diabetes and cataracts, then astigmatism, toric IOLs, EDOF IOLs, trifocal IOLs, and your 2 peer-reviewed studies which are related to EDOF and trifocals, and 1 study is related to Marfan. So sir, let's start with this. First of all, I want to know about your journey. You started your clinic in 1985 with a basement clinic, and now you have created 5 hospital chains in Delhi. So just brief me about your journey.
Thank you. Thank you for asking this very interesting question, I would say, because my journey is very close to my heart. I came back from England in 1984 and then got this small place in the basement in East Patel Nagar, New Delhi, and started my small clinic of about 600 square feet in the basement in East Patel Nagar. And I had my operation theatre and OPD and refraction and a small area for patient to relax after the surgery in the small 600 feet at that point in time, which was decent, I would say, because those days were, kind of days where demands of the patients were not so high. So they were happy with whatever you could provide if they were reasonably good and decent services. And to tell you honestly, I came back with the vision that I'll give the best of the services. So as soon as I came back, I had a slit lamp and a keratometer and a scan for the IOL measurement, and not really a microscope but a loop, 6x loop, which was the thing of that time. And majority of patients or majority of doctors were seeing patients with a torch at that time. And since I had a slit lamp, it was something where the diagnostics was, and observation was much more accurate as compared to the naked eye examination with the torch. And that is why, people were really impressed and happy with the
Outcomes.
yes. So, that is why the practice started picking up within months. And very quickly, I had a lot of patients coming for surgery also. Yeah.
So this, like, you have spent more than 40 years in ophthalmology. So you have made incredible contributions to the field. Sir, why did you choose this field in the first place?
Okay, that's again a very interesting question, because when I was choosing my field after passing my MBBS, I was asking as to what should I do, because at that point in time, medicine was the most coveted branch. And I was also thinking of going into medicine and never thought that I'll be going into the surgical branch as it is. But when I was finishing towards the end of my internship, and when the time to choose the subject or the line which I wanted to follow was there, then I realized that I had a decent surgical hand, and I wanted a branch which was independent by itself. So to explain, if you are a medicine man, you are competing with a general practitioner, or you go ahead and do something neurology or cardiology to become a specialist or any other thing. But in ophthalmology, if you have an eye problem, number of patients will not go to anyone for their eye problem, rather than they will go to a eye surgeon. So this is a small specialized branch which has got its own domain in the mind of the people, and they want to kind of consult an eye surgeon or eye specialist for their smallest of eye ailments. Whereas in any other thing like a surgery, if you have a abdominal pain, then you can go to a surgeon, or you can go to a physician, or you can go to a general physician. In eye pain, the person will straight away come to the eye
So
specialist.
Independent branch.
So this was the most independent branch, and I realized that this is something which I wanted. That I want to be independent of any other, and not to be dependent on any other specialist in medicine. Yeah.
So, sir, you are a surgeon, plus you have done a lot of contributions to the field with your researches. Sir, the question I came in my mind is कि when it comes to Western countries like America or Europe, sir, they are having academic involvement of around 15 to 20%. But when it comes to India or other Eastern countries, the academic involvement in ophthalmology itself is around 10 to 15%. Sir, why we are having less academic involvement than the Western part?
Inquisitiveness is the basis of research. And the education system in India discourages inquisitiveness in a child. Whereas in Western world, a child who is asking questions to his parents or to his teachers, he is welcome and is, encouraged to ask questions, and if they don't know the answer, they try to find and try to explain everything to the child. Whereas in our country, majority of times you will find that if the child is too inquisitive, he is suppressed. So that is why quite a number of times the inquisitiveness is suppressed, And we are doing something like whatever is being done by our, elderly generation. So वो एक धरने पे चलने की जो टेंडेंसी है, and you don't want to deviate from the routine, and you don't want your child to deviate from anything which is not into the mainstream, is the way to go in India. And that is why majority of children are they are doing whatever is there, like to go and study and then go to the job and all these things. We are not going into, like, say, for last 50 years, the only time the sports and other professions are being encouraged is in last maybe 10 years. Earlier, if you go back in 50 years, last 40 years, initial 40 years, the only professions which were kind of encouraged were either medicine or law or engineering and MBA and such things, and not anything except that. Whereas in Western world, if you see, a lot of people will be going into music and also into sports. So those activities were not really encouraged. The basic idea was to do excellent studies, and then whatever is possible you do beyond that. So that is where we differ. But now the things are changing. More and more people are encouraging the research and new things which are, and now probably another few years or maybe a couple of decades will also come very high in that level. Yeah.
So, sir, as you are having a lot of studies in the publications and you are a researcher yourself, sir, what's the best piece of advice you will give to your fellow researcher or a student who has chosen ophthalmology field?
Okay, there are so many things which are, new things happening. And the best thing about new things happening is that there are new things and new avenues to explore. A new machine is, launched, a new technology is launched, a new procedure is launched, and you have access to everything because the availability of machines and technologies are now there in India also. It is well known fact that Indian eyes are not behaving like a Caucasian eye or a white or a black eyes. We are different. Our structure of the eye, our behavior, our healing process, our genetics, everything is different from the normal. But majority of data which we are getting or in publications we are getting are coming out from Western world, which are following the Caucasian eyes or the white people. So we have ample opportunity to do research on Indian eyes and their structure and their behavior, relationship and reaction to the surgical procedures and drugs and everything. And those things are very, very important. They're going to be going into in a long way to modify what we want to use in our country. And we should not blindly follow what foreigners are or white or Western countries are saying and giving us the idea about. So this is where a lot of opportunities are there to do the research in Indian eyes and then go forward and provide the data, new data.
Yeah.
Yeah.
Sir, now let's move on to the second part, which is related to the patients itself, and the part is about cataracts. Sir, cataract is a thing which everyone is going to have in their lifetime if they have that long life. So, sir, with the cataracts, my first question is कि having diabetes increase the risk of cataracts by 2 to 5 times. There is a study about that. Sir, why does this happen?
Diabetes is a metabolic disorder. And when there is a disturbance in the metabolism, the whole body the nutrition of the whole body is suffering. There is damage to the liver, there is damage to the blood vessels, There is damage to the neural and neurons structures and the nerves. So it is a multifactorial disease. And cataract also depends on the nutrition of the person. If the nutrition level and nutrition requirement of the patient is very good and fulfilled completely, then the cataract comes much later. So that's another important fact, that in diabetes there is a fluctuation in the blood sugar which changes the pH. So that changes in the eye fluids, the aqueous humor, also changes the nutrition of the lens, the eye lens, which develops cataract because of the diabetes. So there are two factors. One is the nutrition of the eye, the fluid which is there, the aqueous humor, which we call the aqueous humor levels of sugar. They change. Sometimes it becomes hypotonic, sometimes it becomes hypertonic, and that fluctuation in the tonicity of the aqueous humor changes the nutrition level and hydration of the lens again and again, and that can also cause the cataract to appear early. And the second thing is a wide fluctuation of blood sugar causes everything to happen quickly. Sometimes cataract develops in a diabetic maybe over 24 hours. So these factors are very important. And a tight control of blood sugar and glycemic level is very important for eye health, eye structure, and development of the cataract, and also the health of the retina and optic nerve.
And sir, there are studies which also shows that reducing alcohol consumption slows the cataract progression. Is it true?
Very sure that is true. Because alcohol by itself, there are two things which are happening. Alcohol is a zero nutrition calorie. This is very important to understand. Alcohol, it gives you calories, like it is 4 calories per gram, but it has got no nutrition, no vitamins, no iron, no nothing. No carbohydrate, no protein. So alcohol is a zero nutrition. And the second thing is alcohol damages the liver. Damage to the liver and reduction in nutrition, as I said earlier. Liver disease causes cataract to appear early. Nutrition deficiency causes cataract to appear early. So this nutritional deficiencies appearing in all those people who are having, kind of alcoholic behavior or alcoholic, dominantly alcohol in their, diet. That is why these things happen, because this is zero nutrition. You get calories, but you don't get any nutrition, and you have so much of especially vitamin B deficiency is there, vitamin C deficiency is there because of the alcohol, and also protein. Everything is deficient, and liver also gets damaged. Liver disease is another factor which makes the cataract develop faster. Yeah.
So sir, as there is a one sign, like if somebody is seeing blurry, किसी को धुंधला दिख रहा है, तो it is a sign of a cataract. Sir, this is one of the symptoms. Sir, what are the other symptoms by which we can say ki like there is a chance of cataract?
Okay. So if suppose this is the total lens and the lens is getting opaque. Whenever lens is getting opaque, this is called cataract. Now this opacity could be in the center of the lens, or it could be in the periphery of the lens. So if it is initially in the periphery of the lens, it is not disturb the visual rays, which are light rays falling into the eye. So there might be a little bit of blurriness which can be corrected with glasses. But if the opacity is right in the center of the lens, you will have a lot of symptoms. The first symptom with the central cataract or central changes in the lens will be difficulty in reading, difficulty in distance vision, especially night. Everything is scattering, the light's scattering. In the bright light, since the pupil gets smaller, the central cataract will disturb the vision more. So, difficulty in seeing in good light or very nice light will be sometimes first symptom of the cataract. And then frequent changes in the power of glasses. Few months down the line you will need to change the glasses, and because of that these are the first symptoms of cataract, and gradually everything going hazy, everything like seeing through a ground glass or seeing through a glass with a oil film on it, not very fantastic transparency of the lens. So these kind of things are blurry vision, distorted vision, the color vision perception reduction, the sharpness of the lines. These are the symptoms of the cataract.
So this is one of the good symptoms ki like when you are having that change in the power glasses frequently. Okay.
That's very important. That's most of the time this is the first sign besides diabetes. Diabetes also, if the diabetes blood sugar level increases, the power towards the minus side increases. If the diabetes sugar level decreases, the power toward the plus side increases. So it depends. If you're having a increase in the blood sugar level and having a poor control of diabetes, the power increase changes. But if it is a frequent change in the power, not up and down, but change on one direction only, then it could be cataract. So those both diabetes and cataract will, cause quick changes in the power of the glasses.
Power of the glasses. So, sir, if somebody is having a cataract plus he is having astigmatism too, sir, we know that there are toric lenses which can be an alternate surgery for the patients. Sir, now for the torics, they rotate.
Okay.
Some of the incidents says that toric lenses rotate. Sir, how do you manage this challenge and ensure successful outcomes?
Toric lenses have a cylindrical power in them, and they have to be fixed at a particular angle in the same axis as it has to be corrected. So you have to take the cataract out and put a lens in and rotate it to a position where it corrects the astigmatism completely and fully. Now, if that lens rotates, if it rotates 1 or 2 degrees, it does not matter a lot. But if it rotates more than 3 degrees, then it starts disturbing in the vision, because correction of the astigmatism is neither complete or good, nor the other side is not compensating completely. So there is a cross compound number which comes in, which causes everything to be blurred as seen by the patient. Now there are 3-4 things which are important in lenses where you need that they should not rotate. One thing is, the first important thing is the material of the lens. The acrylic lenses do not rotate as much as the hydrophilic lenses.
Okay.
Right. So the other lenses which are there, the hydrophilic acrylic, they do not adhere to the capsule where the lens is inserted, and since they do not adhere, there is a tendency, if the patient keeps on rubbing, they tend to rotate. The sizing of the lens is important, because if the lens is slightly small size or the eye is large size as compared to the lens which is implanted, then also it can kind of rotate. The material, and also the edge of the haptics, the foot of the lens, they should be very stable and they should be thick enough not to allow. So if there is adhesion all around the haptic, then it is very difficult for the haptic to rotate. So there is adhesion which happens, and then once these adhesions are completely fully developed, then the lens cannot rotate.
Okay.
So material and design of the haptic is very important.
So, sir, as you have done a comparative study between EDOF and trifocal IOLs, in the conclusion you have said that trifocal lenses are great for near visual acuity as compared to EDOF lenses. But sir, trifocal IOLs often cause halos and glares, which some of the doctors on the podcast have said. Sir, why there are halos and glares on the trifocal IOLs?
Okay, this is a very, very interesting and very nice question, I must say. The trifocal lenses have multiple rings, anything from 9 to 14, 15, 16. And these rings are very closely, one after another, they're very close to each other. And these rings have the quality to focus the rays of different distances. Like one ring will be focusing the rays for middle distance, the other one will be focusing the rays from far, and the third one will be focusing the rays for near. So there are multiple rings to focus the rays from middle distance, far, near, everywhere. And that is why when you see in the light, see towards the light in the dark, not in the light, but if you see in the dark towards the light, you will see that there are rings happening all around that light, which could be very large and can be incapacitating if you're driving. Whereas in an EDOF, there are mostly three areas, three rings or three zones. One a central zone, which is good for near, then a mid zone, which is good for distance, and one a peripheral zone, which is good for far. So all these are merged with each other. Very smooth merging is there between these three zones, and not many rings are not there. And that is why EDOF, they do not give any serious glare or cause serious hampering in your vision, distance vision and near vision quality while seeing at the light in the distance, in the dark. So it is, now EDOF lenses are available which have 3 edition or 3.5 edition, which give you a very decent near vision as well. So earlier, when the other, surgeons were, interviewed by you, they probably mentioned of the EDOF lenses which are available at that point in time. Now 2 or 3 EDOF lenses are available which will give you a very decent near distance and middle distance vision for computer and driving and near as well. And they are giving as good vision as a multifocal or a trifocal for all the distances without any disturbing halos and glare of the multifocal lenses with the multiple ring.
Sir, as EDOF and trifocals lenses come in the premium cataract surgery, sir, I really want to know is premium cataract surgery worth for the patients, and does it covers in insurance or not?
What I want to say is that they give you an independence from the glasses for 90 to 95% of the times. So you don't need to put on glasses for reading, distance, computer work, anything. And they are really very beneficial. But I would say that a multifocal or a trifocal lens is not very good for people who are coming back from work in the night and they drive themselves. So I would not suggest. I can say that if they can tolerate a EDOF lens, we can put a EDOF lens and that will be good for them. But a trifocal sometimes is a big hassle for them, a big no for them, because but for the ladies who are cosmetically very conscious and they are don't want to wear glasses, and for them this option is absolutely fantastic. Now with the insurance becoming a major portion of our surgical compensation, the patients have an option. Either they have a insurance policy which covers everything, or they should buy a rider where there is a no limit rider over the insurance policy. So if you have a no limit rider on the insurance policy, then you can get the cataract surgery done with the best possible options like a laser cataract surgery, and also have this with the best option of the lens, because you have already paid the premium of the cataract surgery, and then Over and above that, you have put a you have paid the premium on the no limit on the type of lens which you want to implant. So if you have that no limit rider on your policy, then probably you will not have much difficulty in getting compensation for every type of cataract surgery and the best of the lenses.
Okay. So, sir, you wrote a fascinating case report on Marfan syndrome and you have implanted a bilateral phakic intraocular lens in it. Sir, I want to know what is Marfan syndrome and what are eye-related ocular manifestation in these patients?
So Marfan syndrome is a genetic connective tissue disorder. And this connective tissue disorder becomes significant in the sense that there are so many things which are happening in the eye because of Marfan syndrome. The eye size is big, eye is myopic, overall eye cornea size is bigger, the side to side eye size and front to back eye size is bigger, and the lens which is there is not as big as the eye itself, so it becomes a slightly subluxated lens, which is like kind of ectopia lentis. It is called because it is not right in the center. Sometimes it is shifted towards one side, and it causes lot of disturbance in vision. Other signs are also there, the height and the other factors are also there. But related to eye, this is the important thing, that is the patients are very eye myope and they are not able to see properly, and their development is also not as good. So that is why Marfans is our study on the Marfans was how to treat them. And there is no other way to treat them except for a made to order customized ICL insertion in the eye. So ICL was the best option for these patients because they have a big space in the eye where a lens can be inserted without any problem, and also they can get a very nice quality vision, which is not possible with contact lenses or glasses, because these modalities will not provide as good quality as compared to the phakic lens inside the eye.
So, sir, as you said, the phakic IOL is a best alternative surgery. Sir, why not laser refractive surgery work on these eyes?
Because majority of these patients on having a Marfans in the eye, they have a very high myopia, more than 15, 16, 18, 20 diopters sometimes. So for them, a laser is not a option, because laser we cannot do most of the time up to 8 diopters, and the maximum you can do is about 10 diopters, definitely not beyond that.
So, sir, as you have seen a lot of complex cases in your 40-period lifetime, sir, how do you approach complex cases, and what's your advice for the surgeons that how they can manage the complex cases which they can encounter on day-to-day basis?
For my colleagues, my suggestion will be to be very, very meticulous in their examination and diagnostics. So these two factors are most important in my opinion, that you should be very meticulous, and for the diagnosis you should be able to use all the kind of modalities which are described in the literature, whether it is sending the patient for the scans outside, for a specialized, help of a specialized people who can do better scans or MRIs or such things, and then diagnostics within your center with the UBM, D scans and such things, and OCT, and everything, whichever helps you to reach a diagnosis and to prognosticate the result after the surgery. This is very, very important. Only yesterday I had a patient, like the sibling of a patient I operated almost 5 years back with a congenital cataract. The earlier child was 1.5 months when I operated. This child yesterday was 4 months old, which I operated for cataract. So we must understand that all these cases, what are the chances of having spread what are the chances of having a viral infection causing this kind of cataract like rubella? What are the precautions you have to take for rubella? Whether you can do a rubella cataract with a system where you leave a little bit of lens matter inside, and because that can cause a lot of havoc at a later point in time. So everything has to be very meticulous, and your knowledge and literature has to be consulted, and before you go ahead, do everything possible in your center to do the best results, provide the best results.
Let's conclude this podcast. Let's go to the start. Sir, as we were talking about the innovation, I'd like you to conclude this. How can manufacturers and doctors collaborate to bring out innovations in India also?
And this is very interesting because I have been associated with two or three companies for their analysis. I've worked with them as a investigator for their machines. Like I did an investigator work for NIDAC long back for their hyperopia correction and the software for their hyperopia correction, which was published at that point in time. Or most recently, I have done a clear study on clear, which is the CLEX procedure by Zimmer, where I did the first 43 procedures in India to devise and develop the software which will give the best results for correction of myopia and myopic astigmatism. So you have to have that kind of thirst to see what best can be done, and then sit down with the company and then probably give them an idea that if we can do this manner in a different manner, this procedure in a different manner, and then come out with a better result. That is the way to go to improve the outcomes and to provide the better services to the humanity.
Yeah, so sir, it is a win-win for everybody.
Yes.
Like for the companies also, for the doctors also, and for the patients
Patient
also.
also. Yeah.
Sir, thank you so much.
Thank
to
you.
be on
Thank
the
you
show.
very much.
Sir, it was an honor to speak with you.
Thank you, Satyam, for inviting me for this podcast. I am honored. I feel privileged to be talking to you on this subject.